Okay, hello everyone to another multi-head bioptica session. Today I've got several basic pathology cases and several interesting, mainly brain tumor cases. The first one is quite a rare tumor or lesion type. And this was about 50-year-old female with some non-specific clinical findings. And during the investigation, because of probable cervicobrachial syndrome, they performed some CT and MRI scans of the thoracic and neck region, and they incidentally called the tumor lesion in posterior fossa, so in the cerebellum, and this is resection of the lesion. The imaging findings were quite non-specific because otherwise, if the features of the lesion were typical of this lesion, they will probably not biopsy the lesion. Okay, so we can see this, let's say, malformed cerebellar folia. We cannot see normal architecture of the cerebellum. Because this stratum moleculare is completely made from these dysplastic ganglion cells. No real atypia, no mitotic figures, just these weird-looking big ganglion-like cells, which are let's say, respecting the general architectures of cerebellar folia. I will show you one immunostain. It's NEU1. This is a general neurocytic marker. And here you can see this regular distribution, superficial distribution of these dysplastic ganglion cells. And I also had P10 immunostain, which was deficient in these lesional cells, and the diagnosis is dysplastic gangliocytoma of cerebellum, or cerebral dysplastic gangliocytoma, or Lhermitte-Duclos lesion. This was formerly thought to be hamartomatous lesion, but nowadays probably should be considered benign neoplastic lesion. In this case, we have performed molecular genetics, and it came back with P10 gene mutation with allelic frequency something about 50%, so it's quite suggestive of germline. And eventually the lady was tested and she had germline mutation, and also I believe her daughter was tested and she also has got germline mutation. So this is example of P10 hamartoma syndrome, in which in about 75 to 80% of cases P10 gene is mutated. In the rest of the cases, some other genes may be mutated. These patients are at risk having several, let's say, hamartomatous lesions, but more importantly are at risk of several cancer types, malignant lesions, including breast, thyroid gland, and some GIT lesion, especially colon cancer occurs in this syndrome. What was interesting about this case, the typical imaging findings are, it's like tigroid or radiator-like lesion, and it was not present in this lesion in this patient. So they had several differential diagnostic considerations, including ischemia and other type of lesions, and they were not sure, and that's why it was biopsied. This is benign indolent lesion, very slowly progressive, and even after resection, the recurrence rate is quite low, but they may eventually recur and cause some symptoms. So most of the patients are asymptomatic. They have the lesion, but the symptoms are going from other organs, not from the brain lesion. So that's why we as neuropathologists don't see these lesions very frequently. And this is my probably 5th or 6th case only I've ever seen. So dysplastic gangliocytoma of cerebellum was my first case. My second case is a consult case from Slovakia. It's not from Slovakia, but it's consult case from Prague. And this was a lesion probably in posterior fossa. I'm not sure about the location, and that's it. It's only very minute, very tiny piece of tissue. And the patient is 43-year-old female. And the lesion is clearly primary, so it's some kind of glial tumor. We can appreciate some cytological atypia. No mitotic figures were present there. No necrosis, no microvascular proliferation. And the lesion was IDH1 negative by immunohistochemistry. And we have performed also ATRX immunohistochemistry, which was deficient. And this is some kind of hint to the diagnosis, because we know that that IDH mutant astrocytomas are ATRX deficient, but this is probably not IDH mutant astrocytoma. And I had a suspicion for another tumor type, which is called high-grade astrocytoma with piloid features, which in most cases presents with this quite a low low-grade histomorphology, but in fact is high-grade astrocytic lesion with dismal prognosis, only a little bit better compared to classical IDH wild-type glioblastoma. So how you can do the diagnosis? You can do it only by methylation profiling, and indeed methylation profiling came back as high-grade astrocytoma with piloid features. So in this case, it's not that piloid looking, so the histomorphology is very non-specific, and you should think about the lesion in, let's say, typical clinical setting, in posterior fossa lesion, adult case, ATRX negative tumor. You cannot really classify by other immunos on genetics. You should think about this tumor type and send it for methylation profiling. Okay. So this is another brain tumor. It's a child case. It's 6 years old, female. Again, location. I don't know the location, but based on what I know now, it's probably supratentorial lesion, and maybe located somewhere next to chiasma opticum or somewhere in that region. And in this low magnification, we can see it shows this myxoid features, and tumor itself is composed of these round or a little bit spindly cells. Not that bad atypia, no mitotic figures were present, no necrosis. The proliferation activity was very low, and it came with a differential diagnosis, and they performed some genetics, especially Kia-BRA fusion. They tested for that, but it was negative, so that's why they sent it here. So I performed again methylation profiling, and it came back as a pilocytic astrocytoma midline with a very high probability score, 0.96. So 96%, for 96% the methylation classifier is sure it's pilocytic astrocytoma, and based on morphology I would call it as pilomyxoid astrocytoma. In the previous WHO classification, the tumor was considered rather to be grade 2 compared to conventional pilocytic astrocytoma, which is considered to be grade 1. But in the last WHO classification, we probably should not grade the tumor, and it's probably more like grade 1 tumor. So anyway, it's low-grade lesion, but this pilomyxoid astrocytoma, just because the growth pattern is not that well circumscribed, is myxoid, may envelop adjacent structures, including optic chiasma and nerves. It's harder to be resected, and recurrence rate is a little bit higher compared to pilocytic astrocytoma. So the second diagnosis is pilomyxoid astrocytoma, probably grade 1. And another case, it's a really difficult lesion. It's a 47-year-old man with a tumor lesion in the parieto-occipital lesion. And they sent this. So already quite interesting things can be seen. You can see these hyalinized and even calcified vessels. It's almost always a clue to some low-grade lesion. Okay, so you can have this type of vessels for pilocytic astrocytomas, for example. And tumor cells by itself are, again, roundish, not that big atypia, not very much of mitotic activity, no necrosis, no true microvascular proliferation. And just based on these morphology, some hemosiderin was present there. Okay, so maybe some fold hemorrhage. Just based on histomorphology, I had no clue. Okay, maybe some perivascular papillary arrangement. So this is something low grade, could be pilocytic astrocytoma, yes, of course, some neuronally differentiated lesion, yes. Okay. So interestingly, the lesion was positive for Olig2, which is a general glial marker. So some nuclear Olig2 staining can be seen. The lesion was diffusely positive for synaptophysin. This already is quite unusual, but we can see like glial and neuronal markers in many astrocytics and neuronally differentiated lesions. So again, it's not very specific, and it's there. And importantly, again, NEU-N antibody was negative, because if it would be positive, it will be a great clue to the diagnosis, but unfortunately it was negative. So based on his histomorphology and immunophenotype, I had no clue. So again, I performed methylation profiling, and it came back as extraventricular neurocytoma. So these are low-grade, grade 2 lesions, and in contrast to more common central neurocytoma, which is located near to the chambers, to the ventricles, these lesions have very typical, not specific, but typical translocations, and these are FGFR1, TACC1 rearrangement is very typical for this lesion. And in contrast, central neurocytoma has no recurrent genetic alteration, so this is quite weird. So this is very, very rare example of extraventricular neurocytoma. Even if I had performed molecular testing and it came back with this FGFR rearrangement, it's still non-specific, so I would use methylation profiling anyway. And it's a child case, so you should do your methylation profiling for every child case. Okay, the next patient is male, 57-year-old. Yeah, and this was very difficult again case. The tumor location was not quite clear for us, but after discussion with the surgeon, he sent the case with the diagnosis of probably metastatic disease because the lesion was very superficial and almost like extraaxial in location. So they felt that it's not in the brain parenchyma, which is very, very strange. And you can see this very monotonous proliferation of these cells with some pseudo-rosetting or maybe some rosetting pattern. So it looked like, could it be some metastatic neuroendocrine tumor? Maybe, yeah. Could it be something primary? Of course, could be. No many mitotic figures were present. The histomorphology again is quite non-specific and maybe low grade. Not many mitotic figures were present, probably no necrosis as far as I remember. And the lesion was this positive for synaptophysin, so very strong and diffuse synaptophysin positivity. I believe that keratins were negative. This is OLIG2 staining. So again, OLIG2 is a general glial marker, positive in many glial and neuronal neuroglial lesions. In addition, GFAP, glial fibrillary acidic protein, was very strongly and diffusely positive, so that the immunophenotype is a little bit confusing. So we have performed some genetic testing, which came back with third gene mutation. It's again non-specific finding. And we eventually performed methylation profiling, which came back as oligodendroglioma. This was quite surprising. And this is the actual report for Heidelberg classification with the diagnosis of oligodendroglioma. And you can easily see on copy number variation plot that there is 1p and 19q deletion. So we had we didn't perform fish studies because it's very clear that the tumor has got co-deletion of 1p and 19q, and this really confirmed the diagnosis. IDH was negative by immunohistochemistry, but positive by PCR testing. So the tumor had alternative, less frequent IDH, I believe IDH2 gene mutation. So this is very tricky case by location, clinical findings, was negative by immunohistochemistry, and I don't know what will my diagnosis be if I wasn't be able to test it by methylation profiling. So very tricky one. This probably was my last CNS case. Okay, my next case is very basic and easy. It's a 35-year-old male patient, so young adult, with a skin lesion on his arm, and the lesion shows quite typical histomorphology. So I brought it here because it's very nice and textbook example of this kind of lesion, and you can see these multinucleated giant cells with this very characteristic arrangement of nuclei, and these cells are called two-tone cells or floret-like cells. And in addition, you can see these foamy macrophages in there, and in addition, some mononuclear histiocytic cells in the background with this huge amount of eosinophilic cytoplasm. And I didn't perform any immunohistochemistry in this case. It's very easy, and the diagnosis is juvenile xanthogranuloma. You can put the word juvenile in brackets or in parentheses if you are making a diagnosis of juvenile kind of lesion in an adult patients, just to keep older persons humble. Okay, because otherwise they will show up with your histologic report that they are still juvenile in their 30s or 40s. So juvenile xanthogranuloma, it's not that common lesion, it's quite rare, but it's most frequent non-Langerhans type histiocytosis in humans. So juvenile xanthogranuloma, it's completely benign, but in cases with systemic involvement, especially liver or some other organs, it can be quite serious and even fatal and should be treated. So my next case is a 37-year-old female, so young lady, and this lady had a family history of stomach cancer, and she was tested and she was found to have a germline mutation in cadherin-1 gene. So she is at risk of having this diffuse carcinoma of the stomach or poorly cohesive carcinoma of the stomach, and some other types of lesions, including breast cancer. And prophylactic gastrectomy was performed in this patient. And in these cases, I have showed a case like this before at this seminar. You should submit the whole stomach. So it was submitted in some, 130 something blocks. And this is the only site in the only one block with this kind of lesion, and this is, I believe, cyanide ring cell adenocarcinoma in situ. So it's not invasive. In fact, they saved her life by preventing invasive growth of this lesion. So you should always submit the whole stomach to rule out invasive cancer. So that's it. It's quite a job to do it, but we have to do it. So this was a cyanide ring adenocarcinoma in situ. Okay, another case is an adult patient with a lesion in maxillary sinus, and they curated it and sent it with a diagnosis of aspergilloma. You can see some sinonasal mucosa inflamed. And fungus is there. Yeah. So this is very short IFA. So this is not very typical of aspergillus I've seen so far. So and moreover, there were these brownish cystic structures here with some spores within these cystic structures, and moreover there are some bigger, you can see these roundish translucent but thick membrane structures. These are called, I believe, Hull cells. So I was not sure about the fungus. Of course, we as histopathologists, we are not able to do like correct classifications of fungi, and they should like cultivate it and do the tests at the microbiology department. And what we can do as a pathologist, we can send it for molecular classification, and this is what I have done. And it came back as aspergillus nidulans, which is quite a common fungus. In fact, it's one of the most studied, and we have a lot of information on this fungus. And I will include on our web pages this one page, facts about these aspergillus nidulans. It's a mold which was even brought to the space station, and they performed some science with it, and it's used even in the industry to like produce some substances, including antibiotics and other stuff. So aspergillus nidulans in Sinonasal biopsies and as fungus bowl or aspergilloma. Originally, this fungus was thought to be quite indolent, but recently they described even some invasive infections of this kind, so it's not that innocuous as originally thought. Okay, I've got one frozen section case. This is a 45-year-old lady, and she came with a huge tumor of the ovary, which was about 33 centimeters in the largest dimension. The surface of the ovary was shiny and clear, and on the cut surface it was solid and cystic, very fleshy looking lesion, quite eye-catching appearance. And of course the question was, what's the diagnosis? So I will show you frozen section first. So we can see this nested growth pattern of something basaloid. In fact, the case is quite easy, and I made correct diagnosis, okay, on this frozen. So solid, and when here you can see these rosetoid structures, and this is very high magnification. I probably cannot show you. So frozen section always changes the nuclear characteristics of the cells, and even benign cells may look quite angry because of these frozen artifacts. So what I always do, if it's possible, I do the cytology. And in this case, you can make like a scrape the surface of the lesion with the blade, and then spread it on the slide like butter. Okay, this is what was done in this case. And the advances of perioperative cytology is that the frozen section will give you like architectural clues to the diagnosis, but cytology will provide you with cytological details which are not hampered by freezing. And you can see these oval cells with some grooving, or let's say coffee bean morphology, and even in cytology you can see these rosetoid structures which are called Kohl-Exner bodies, and the diagnosis is Granulosa cell tumor of adult type, and this is definitive biopsy of the lesion which recapitulates what we have seen in frozen. It's very typical, this solid and cystic and rosetoid structures. This very typical granulosa cell tumor of adult type. Do you have to perform immunohistochemistry? It's not really necessary for the diagnosis. The lesion is positive for, let's say, calretinin, alpha inhibin, and most cases will be positive with FOXL2 antibody, because majority of these tumors have FOXL2 mutations. In our lab, we had FOXL2 antibody, but it's not working anymore, so we don't use it, and in fact you don't need it, because the diagnosis is based on histomorphology. This is a tumor of it shouldn't be called benign. It's not clearly malignant in every case, so it's unpredictable biologically. And what is very typical of this tumor type is that you may have metastatic disease many years after resection of the tumor, after original diagnosis, typically 5 or more years. And I have seen many patients with metastatic disease, let's say 20 years after original diagnosis. So it's tricky if you see it as a metastatic lesion, because the patient some patients will forget about previous operation and they had something. So you should always think about that. So my last case is a tumor sent as with the diagnosis of glomus body tumor, and just by saying that, the differential diagnosis in your head, you've got only one possibility. Okay. So lesion, the biopsy is not nice, because they like baked it with current, because so these are all artifacts caused by worm knife, and the reason is the region is bleeding. Okay, they are trying to resect it, but the typical morphology is here. So it's this nested cell balance architecture of epithelial cells. So we might perform, for example, reticulin staining to highlight this cell balance architecture, and the lesion is typically immunohistochemically positive for GATA3. This is excellent marker for this tumor, and the lesion shows synaptophysin positivity, very strong and diffuse. The lesion is positive for chromogranin, and if you wish to have like textbook immunohistochemistry, you can perform S100 protein or SOX10 immunohistochemistry, which will show you this peculiar pattern of so-called sustentacular cells present there, and the diagnosis is extraadrenal paraganglioma. So we as a pathologist should do one additional staining as a screening for syndromic association, and this is SDHB staining, which in this case was retained, so probably this case is not associated with SDHB mutation. But there are some other syndromic associations, so still clinicians should test in that particular genes, especially if there is some clinical history.
It was in the carotid body?
Yeah, carotid body, extraadrenal paraganglioma is the diagnosis. And that's it from my side.
Good afternoon, it's Michael Jr. speaking. I have some few generally easy cases. The first one is very easy, very basic, but I thought it's a good example of this tumor for residents. It was a 60-year-old male, tumor in his inguina, and it was 18 centimeter in size. So what do we see here? The first assessment is easy. We see some very well differentiated lipomatous tumor. Obviously, the majority of lipomatous tumors in this location in peripheral soft tissues is just a benign lipoma. I get all the lipomas from the faculty hospital, so it's generally like a 2-second diagnosis. But here, you kind of stop because this is looking unusual for lipoma. So the first thing you can mention is that the size of the fat vacuoles is not very uniform. There are huge differences in the size. In normal lipomas, the variation, there is also some variation, but it's not very great. Generally looks like a normal fat. And the other thing you may notice, especially on the scanning magnification, is that there are these quite thin but quite numerous fibrous septae. And if you go on a higher power and look into these septae, you see these hyperchromatic spindle cells like this one in the center. And these are basically clue to the diagnosis. It's easiest. You are basically looking for hyperchromatic nuclei of the cells. They can be either in the adipocytes, like at the periphery of the fat vacuoles, but it's much easier actually to find them in the spindle cell septae. So I recommend first looking into these septae for them. And so this is because we are in the inguinal location, peripheral soft tissues, this is atypical lipomatous tumor. If the same tumor was in the retroperitoneum, this would be obviously called well-differentiated liposarcoma. If you look here, another not very remarkable, but still hyperchromatic spindle cells. These are clue to the diagnosis. These should not be present in ordinary lipomas. You can do MDM2 immunohistochemistry or FISH, but here basically the diagnosis, in my opinion, or the findings by morphology are sufficient to call this on hematoxylinosin stain. Again, the septae with these in this area is also plump, but also hyperchromatic spindle cells. These cells would basically shine with MDM2. Here in the middle, in this area, you can see a nice lipoblasts, but they are absolutely not necessary for diagnosis. This is another block from the same patient. I kind of noticed here, I think there should be some, here you have the adipocyte vacuole, and at the periphery you have these hyperchromatic nuclei of the adipocyte. So here you could actually see the atypical nuclei also in the adipocytes with fat vacuole. here again, it's weird atypical stroma. So atypical lipomatous tumor. Another pretty ordinary case was a 15-year-old male, tumor on his hand. And we had these 4 sections from tumor, which was very eosinophilic on low magnification and was composed of these kind of little, let's say, nodules again, which were centered. They had in their center these prominent vessels. And if you look at these nodules centered around the vessels, you can see kind of like a concentric arrangement of the neoplastic cells. This is what we call pericytic arrangement. So this is likely to be some pericytic tumor. The tumor cells are kind of you cannot very well appreciate the cell borders like you can do in glomus tumor, which is one of the pericytic tumors. So this does not look like a glomus tumor really. This looks like more of like some myoid thing. Very eosinophilic cytoplasm abundant. This is smooth muscle actin. So the whole thing is diffusely strongly positive. You can beautifully see in the smooth muscle actin the pericytic arrangement, concentric arrangement. So the diagnosis here is myopericytoma, benign myopericytoma, completely benign tumor. In the previous WHO classification, this was classified as a different entity from another pericytic tumor, which is called myofibroma. But today because we know about cases which have features of both myofibroma and myopericytoma, and we know that both tumors have PDGFRB mutations. And for this reason, both tumors are now classified as one thing. So basically myofibroma / myopericytoma, and they are in the section on on pericytic tumors. So again, perivascular arrangement, concentric arrangement, myoid appearing, something smooth, muscle-ish, eosinophilic appearance, SMA positivity. So myopericytoma. Next case was a 88-year-old female with a tumor on her face, skin excision. And here on the surface is the epidermis, and probably the first thing you notice is this absolutely excessive solar elastosis, which is quite rare to see in this amount. So here solar elastosis, and then when you look around the epidermis, these areas look quite normal, but here it starts to look a little bit funny. Unusual. Here there's a thinning of epidermis. Here it's torn. Here, I think I just want to say this looks suspicious for dysplasia to me at least, which in concert with this excessive solar elastosis is quite likely anyway. But the main problem here is this proliferation of spindle cells, which is infiltrating the dermis and subcutaneous tissue. And if you look on higher power, this is there is a lot of hyalinized collagen, but especially in the deeper section, you can still appreciate the spindle cells which are atypical, hyperchromatic. You can see quite a few mitoses here and there, so this is definitely something atypical in this setting. Old patient, face location, and actinic damage of the skin. Definitely the first thing you should exclude is some spindle cell melanoma. So you need some immunostains, S100, SOX10, HNB45, everything was negative. The next thing you can think about is some leiomyosarcoma, so you should do some caldesmon, which is also negative. and especially in the setting of, again, actinically damaged skin with suspicion for dysplasia of the surface epidermis, you should think of squamous cell carcinoma, or rather sarcomatoid variant of squamous cell carcinoma. So you should do first some cytokeratins, ideally cytokeratins 5 and 6, but this was a consult case, so I'm showing what I got. This was AE1, AE3, so broad spectrum cytokeratins. And this looks mostly negative, but in some areas you can see some weak focal positivity. And then you should use some markers for squamous cell differentiation, so P63, P40. This is P63, and we do see some clear nuclear positivity in the tumor cells. The cells that are positive are larger, quite plump, so that these are there's a high chance these are, or almost certainty that these are neoplastic cells, the same in the D proportion. So it's not diffuse, but it's positive. The same with P40. In this case, it looked very similar. So these are some nexal structures, but the cells around here are again positive. So I think when you put all the findings together, actinically damaged skin, old person, tumor on the face, suspicion for epithelial dysplasia, spindle cell atypical proliferation with this immunoprofile, I think this is sufficient to call this sarcomatoid variant of squamous cell carcinoma on the face. And my last case, it was a 37-year-old male, tumor on the peritoneum. And I'll start with scanning magnification. So you see this nodule with some calcifications already on low power. And if you look into the nodule on higher power, you see basically mostly fibrous tissue with some quite bland fibroblasts and some inflammatory cells. And then these very prominent calcifications again. Some vessels. And basically the only thing that was a little bit worrying, I think, here was this spindle cell proliferation. So in general, the areas I've shown here, these parts, they look like a very typical case of calcifying fibrous pseudotumor of the peritoneum, which I think this is. And the only thing we need to explain is this proliferation right here. So some highly cellular spindle cells, which, although despite the cellularity, are quite bland, there is nothing really that worrisome about them. And if you do immunohistochemistry here, you'll find out these cells are positive for, find the area. This is cytokeratin AE1, AE3. And the cells are, here it is. The cells are diffusely positive for cytokeratins. Then we have SMA here. Again, diffusely positive for SMA as well, smooth muscle actin. And desmin is shown here. Very nice positivity for desmin. So this is basically immunoprofile of so-called submesothelial fibroblasts, which are cells that tend to proliferate whenever there is some irritation or injury of the peritoneum, and they can look quite worrisome. It's a very frequent source of consultation. it's a cellular proliferation of spindle cells, but they shouldn't have atypia. They typically have this immunoprofile, cytokeratins, desmin, smooth muscle actin. You will find also some expression of mesothelial markers, but they were not done in this case. So I think this is just a reaction basically to this calcifying fibrous pseudotumor, which is otherwise completely benign lesion. It's pretty rare case. I haven't seen one in a few years. So that's all from me. Thank you.
Here is Michal Michal Senior. I will show you a case that similar one I showed you in previous questions of ours. It's solitary lesion of the skin in middle-aged man. And what you see here is such wild sebaceous proliferation. But if you see carefully to the stroma, you see. Co?
Máš to rozmazané.
Aha. Já jsem viděl to. Yeah. You see wild sebaceous proliferation.
Where is this located?
It's I don't know. It's not important. Yeah.
Okay.
Maybe anywhere. Yeah, it's nasal. Nasal skin. And when you look down to the stroma, you find here spindle cell proliferation with lipomatous cells. Rarely even as lipoblasts. And this stromal lesion is typical of spindle cell lipoma, according to me. Here is retinoblastoma protein. Even you see that most of the cells are retinoblastoma protein negative, positive are only vascular endothelias. What you see, which is typical, the sebaceous part of it is retinoblastoma protein nicely positive, which means it is basically spindle cell lipoma with hyperplasia of sebaceous tissue, and in the past these lesions were called trichodiscomas. The name of trichodiscoma was as though the sebaceous proliferation was the primary thing, and nobody before that noticed these stromal cells. We think that these lesions are primary, the stromal thing is primary, usually spindle cell lipoma, sometimes pleomorphic lipomas, sometimes so-called retinoma protein deficient fibroma, and all the sebaceous proliferation is reactive to it. Yeah, so that we still think this is an epithelial tumor. All those trichoblastoma, they are just reactive hyperplasia over it. I gave you already a reprint of it. We did years ago about 25 cases of this, which is now very widely cited, and this theory of ours is recognized. Now I have a case of tumor on the chin of an older patient. What you find are these microfoci which look like balls, concentric balls, which invade the stroma of dermis and can even show perineural invasion. But what I do not remember to have ever seen are these clear cells. You see them. The clear cell in the middle, yeah. Now in the middle, yeah. Or here, the clear cells. It's not very well seen the details of it, but these clear cells, we looked in it adipophilin. It's quite apparently that these clear cells, like the one in the middle, are adipophilin positive. Or here. Can't find a pointer, yeah. So that we think that it is microcystic adnexal carcinoma of the skin, which is typically on chin or periorbital region, with sebaceous differentiation. Until now, we have many of these tumors in our files, and I don't remember seeing adipocytic differentiation in these tumors, but this should not be surprising because these lesions are definitely not of eccrine origin, they are probably of follicular hair follicle origin. And the last case is, I show you, is tumor of ovary. Which came to us in consultation with diagnosis of ovarian adenocarcinoma. And what is typical of these lesions are these hyperchromatic slough of cells into the cells inside of it, yeah. This you can find them in nearly 100% of the cases. Do you these debris inside of the glands? And I show you SARB2 immunostaining. The diagnosis is clear cut, yeah. So SARB2, the same as CDX2, is positive, yeah. And these intraglandular cells are positive, so that it's metastatic colorectal adenocarcinoma to the ovary. And these sloughing of cells into the glandular structures are not well recognized in the pathology. It's my own experience, are practically nearly pathognomical for colorectal metastatic lesions, and if they are much more expressed, they make even solid foci, and then we speak about powder cell-like change of nuclear dust, and it is published in the past as being typical for colorectal adenocarcinoma. Thank you for attention. It's all.